The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with LeadingAge Michigan. And again, we want to welcome you to our Safe and Calm webinar series. It's finally Friday, and this has been a very busy week. And today, we're going to focus primarily on two things, reporting and testing. We're not going to do a situation update this morning, but we do continue to track the numbers daily. The caseload has gone up just a bit for the last 3 days, so we're watching it to see if this is just one of those short upward spikes or a trend change. But overall, Michigan continues to do very well compared to other states in terms of the downward trends. Dalton's going to provide a brief update on our advocacy work this morning. There has been a lot of movement for legislation that we've been tracking. And we will be doing an overview of the reporting guidelines, guidelines for AFCs, HFAs, and assisted living, as well as nursing homes. The reporting elements are the same for all those entities with just a few exceptions. And then following that, we will go directly into a review for nursing homes only so that our other provider members can jump off the webinar at that time. So with that, we're going to turn to Dalton, who will give us an update on all the pertinent legislation that he is tracking right now. Dalton.
Good morning, everyone. Welcome to Friday's webinar. Today, we're going to touch on some of the debate going on right now in Lansing. There's a lot of, I'll say, political posturing, gearing up for the election, the upcoming re-election, especially for the House of Representatives, as everyone is up for re-election, and it is predicted to be a very tight race, and control of that chamber is at stake. We're also going to be discussing Senate Bill 690. While it hasn't passed the it's passed both bodies, the House and the Senate, it is not currently a law as the governor hasn't signed it. And then we'll be discussing just briefly some stuff about the Elder Abuse Task Force that met for the first time since January. To start, we'll be discussing some of the debate going on in Lansing right now. This week, multiple committees have met and have discussed a variety of things, from actual legislation to House resolutions to just kind of grilling in to department officials. The legislative Republicans have really wanted to build a re-election platform that focuses on nursing homes and the state's decision to move COVID positive residents or individuals into nursing homes. This is going to be one of their big political platforms that they use to give them leverage in the next election. So far, we have seen a focus on the communication between MDHHS and LARA and their response and who was responsible for what. They're really grilling into those two departments to see where things may have gone wrong or where there may have been some miscommunication that they had. Other issues on there's issues of staffing, testing, the alternate care sites, and funding for all of those things are all baked into this. Largely, people are very concerned about COVID positive residents being moved into places where the most vulnerable people to COVID reside, and it's going to be a big talking point going forward. And so you can expect to see the spotlight on long-term care grow as the election cycle starts ramping up. A good example of this is, you may have seen it in the news or in some articles. Yesterday, the House and the Senate both passed resolutions opposing the governor and state's decision to put COVID positive residents in nursing homes. Republicans spoke in both chambers very passionately about opposing the decision. Both resolutions were passed in the Senate along party lines, and in the House, interestingly enough, it was not along party lines. Some of the representatives who are Democrats, who have districts that are very moderate in terms, they don't lean one way heavily or the other in terms of their politics, voted in favor of the resolution. Those lawmakers who were Democratic lawmakers who didn't vote in favor of the bill were then attacked on by Republican media later that day for not agreeing with the resolution. And so that's just some first signs and an example of what this is going to be going forward. Moving on, Senate Bill 690 passed the House on Wednesday and passed the Senate on Wednesday like we thought. A couple of key things to note here. The bill package was stripped down in terms of overall funding. It's down 40%, 50% from where they had it at one point. It's total of $880 million now, down from 1.3 to 1.5 billion at one point. Additionally, this is not currently law. It will be law if the governor chooses to sign it. All signs point that she will sign it, and we'll have a release that goes out when she does sign it, but it is not currently law. So in this $880 million, there's three specific areas that affect LeadingAge Michigan members. There's $120 million for direct care worker hazard pay payments, $25 million for PPE and testing grants, and $1.5 million for expanded infection control surveys by LARA. And so that's a total of $146 million roughly that relates to long-term care. Next slide, please. There we go. Start off with some more detail here. The direct care worker fund. These care workers have to be employed by a SNF or a AAA or contracted with MDHHS, and then they will receive a $2 hazard pay increase, $2 an hour hazard pay increase. We previously thought it would be $3, but with the package losing so much funding because they want to spend it on backfilling the budget, they lowered this to $2. Eligible workers for those employed in the SNF include registered nurses, licensed practical nurses, competency evaluated nursing assistants, and respiratory therapists. And eligible workers in the AAAs are in-home and respite care service workers. Specific language within this, these $2 an hour rates are based on March 1st, 2020. They go into effect July 1st, 2020 and go through September 30th, 2020. And they apply to all staff employed on the effective date of the legislation. The funds include all costs incurred by the employer, including payroll taxes. This means that direct care workers who qualify for these payments will not see a direct $2 an hour increase on their paychecks. Any pay enhancement above the hourly rate on March 1st does not count towards the average compensation provided by any contract. And because of this, we urge members to have their HR departments or a contract specialist look into their collective bargaining agreements to see if this has any impact. Employees can also refuse the payment increase if they'd like. Moving on to the PPE and testing grants. This is a total of $25 million. Eligible providers, I have the list there. The two that apply to us are long-term care facilities and residential congregate facilities. The bill does not specify who falls into what group. We submitted language early on in the process that to include all provider types in these two definitions, and we were told that the intent is to have them all covered underneath these definitions, but there is no formal definition set out for these grants. An important thing to note, we can move to the next slide, is that the MDHHS is responsible for the implementation of the grant program and also the application. In other states, people have found are having some difficulties because their department is making determinations on the application that don't really make sense with what their laws say. Any purchases made on or after March 1st are eligible. These purchases include personal protective equipment, COVID-19 testing equipment, and then MDHHS has to report to the House and the Senate by September 30th. We're working with people to craft the language around the grant process and application, and we're hopeful that the department is listening and will create a smooth process for providers to receive these funds. The last thing that we're focusing on for this bill package is that LARA received $1.5 million to conduct further ongoing infection control surveys throughout the state. These are not focused in any one region. A specific quote from the legislation is that if necessary to connect nursing home providers with MDHHS Public Health Division to provide the necessary education and training to the facility staff and clinicians to maintain infection control practices that mitigate the spread of COVID-19 infections. We believe that LARA and MDHHS are going to be a bit more aggressive in their infection control practices, as they've been receiving a lot of political feedback that they haven't been doing a good job so far. And so they're going to be tightening down the hatches going forward. Lastly, just to briefly touch on the Elder Abuse Task Force. It was the first time it's met since January. A lot of the task force subcommittees are still on hold because of COVID and the various stakeholders included in each of these. The big thing that came out of this is that the task force is looking for funds to pay guardians. They're thinking roughly 14 million general fund. They realize that it's an uphill battle right now because money is so critical in every aspect of political life right now. The next true point where they can get some funds will be in August, when the budget debate continues after the summer break and the campaigning season.
All right, so I do have a couple questions, but before we can get to those questions, LeadingAge Michigan would like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference despite it being temporarily postponed. We look forward to your continued collaboration and we remain grateful to you. Now for a couple questions. Someone said, please expand on what you meant by this means employees will not see the full $2 in their paycheck.
So because the $2, the funds you will receive as an employer are inclusive of costs, it means employers have to take out costs to them before they distribute the funds to the employees. So for every $2 that an employee receives, you will have to take out payroll taxes of that $2 before they get distributed. So an employee isn't going to see a $2 increase, depending on what the payroll tax is. It will then deduct from that $2 that amount. I hope that made sense.
Okay. Regarding the SNF governor issue, do we have any idea if this will have any immediate effect on providers? Will she issue new executive order that changed direction of 2020-123?
The SNF governor issue, I assume we're talking the placement of COVID positive residents in SNFs. I have not received any indication that she's looking on changing that legislation. In fact, there's a Senate Bill 956 or 650, it's one of those, I think it's 956, that the legislature is looking to move through that would disallow nursing homes from maintaining or admitting or retaining, COVID positive residents. It's expected that the legislature is going to move that through based on party lines, and then once it hits the governor's desk, she won't sign it. And based on the recent things we've seen with testing, she seems to be taking a hard-line approach here to nursing homes and what exactly is expected of nursing homes. So we'll see what happens throughout the political process, but right now I don't think she's rethinking that.
All right, sounds good. Is there any discussion on housekeeping and dietary staff being eligible for the $2 increase?
No. The $2 increase is truly for just those 4 groups. This is kind of a labor positive move here from the governor and from the legislators. They're really looking to provide these specific labor groups with this bonus. We're in the future, if the funds don't get all used to backfill the budget, there's still $2.2 billion out there in CARES Act funds that haven't been allocated. And if the federal government doesn't allow them to backfill the budget, we are looking to include other staff in a direct care payment kind of model. We realize that this doesn't touch all provider types, and we also realize that this doesn't touch all the workers even within SNFs. So it is something we're looking at going forward if the federal government doesn't allow states to use this $2.2 billion to fund other things.
All right. So that is all the questions that I have right now, so we can move forward. I also did just want to mention that in the handouts, little tab right there, you should be able to download the PowerPoint for it. We only did the PowerPoint version because for some reason, when I've been putting the PDF on here, we've been having issues with it and people haven't been able to get it. So hopefully this one works. Other than that, I think we are good to move on. Deanna?
Okay, great. Thank you, Blake, and thank you, Dalton. So we're going to move on to testing and reporting now, and we're going to start with reporting guidelines for all entities, mostly because there's been some confusion noted in 2 particular areas that could potentially overstate the COVID numbers in your facility, and also because the state is drafting FAQs, at least for nursing home testing and reporting. They've not been put out yet, but they have given us what they call the final draft. So they might be tweaking that as we speak, but we are going to go through them today anyway because there's some differences in some areas that we've been talking about. So here are the 2 guidances. One is for nursing homes and one is for AFCs, HFAs, and assisted living. We've included the links for those guidelines at the top of the slide as we usually do, and of course we will include those links in our Q&A. So the CMS final rule identifies the elements that has to be collected for nursing homes. And these are the foundation for reporting to the CDC through the NHSN system. That reporting requirement is for nursing homes only. The NHSN system can, though, accept data from other provider types, such as assisted living levels of care, but there's no Michigan requirement for assisted living providers to do that. And so there was some confusion about that in the very beginning of that reporting process. MDHHS, the department, has aligned its reporting to meet the same elements and definitions pretty much for all the settings. In other words, even though assisted living settings don't have to report to NHSN, they are reporting almost the same elements with the same definitions. So there have been some problems with the MDHHS reporting piece. The department has set up a way for nursing homes, if they enter their data into EM resource, that data is supposed to automatically upload, and there have been some problems about that. We will talk about that in a few moments. So for nursing homes, facilities must report daily, and that includes the weekends. There's a lot of controversy, if you would, about having to report on weekends because staff is lean and caregivers are needed to take care of residents. But the state is not backing off from that daily reporting requirement, 7 days a week. And that reporting is for the previous 24-hour period, midnight to midnight, has to be submitted by noon daily. And of course, you must have all your contact information correct in order to be credited for your reporting. So there were some problems with getting the right CCN number and the right NHSN number sometimes, but I think that that's pretty much working now. And the department always notes that reporting requirements to local health departments are not changed because of this guidance. You still have to report in the same way to local health departments. For HFAs, AFCs, and assisted living, reporting is only required weekly, and that is for a 7-day period starting Monday and ending Sunday. Data must be reported by Monday at noon into Survey Gizmo, while nursing homes are entering their data into EM Resource. For all the reporting entities, the department uses the CDC guidance with some additions that they have added, obviously. And there are specific instructions on how to do your first reporting. Everybody should be past that already, so we're not going to go into detail about that. The department generally looks at things in a cumulative way, although you can enter back information into the NHSN system as well if you're a nursing home. But the CDC on an ongoing basis generally looks at things that have changed since your last reporting. The department looks at cumulative information as well. So there's 3 elements here that have been the areas that some providers have identified as confusing. And these have come up in numerous of our calls with the state lately. And I think the state finally understood what providers were saying. So admissions, persons admitted or readmitted who are previously hospitalized and treated for COVID-19. So these were people who were in the hospital and had a diagnosis before they reached you. There are no facility acquired cases counted in that number. And that's kind of self-evident because these are new admissions and they have that diagnosis. Confirmed and suspected, these are only facility acquired cases. And apparently some providers were putting their admission numbers in their confirmed numbers as well. But you're not supposed to do that. So your confirmed and suspected categories are only supposed to include facility acquired cases. So what we're still not sure of is when you have a facility onset case that goes to the hospital, you've counted it as a facility onset case, and obviously you count them at onset, but then are you supposed to count them again when they return and are readmitted? That's not clear, but I would think not, because that would inflate your numbers as well. But there is no defined guidance for that at this point. For these elements, these are, remember, the CDC elements. Report only for the time period since your last reporting, so not cumulative at this point. So for providers who may have inflated their numbers, the department is considering what to do if they were double reporting. They have not come out with an answer for that yet. That's very clear. So for total deaths and COVID-19 deaths, same protocols for first reporting and getting started. The total deaths include any residents who died for any cause during that time period, while COVID deaths are only those with positive or suspected COVID. So if you suspect COVID, you are supposed to put those numbers in there as well. Obviously, your COVID deaths should generally not exceed your total deaths, at least not for MDHHS reporting. Even if you don't have a death certificate or final diagnosis, that COVID suspected category allows you to put those patients in and report them as well. If there is someone who had COVID but recovered and then later died, they should not be included in the COVID count, only the total death count. So these next elements are pretty easy. The number of licensed beds, nursing home or assisted living level beds, and these can be updated if your bed numbers change. For nursing homes, it does include non-available beds. So the reason for that is that they're looking at potential capacity if another surge should hit. The current census includes the numbers for only the day of reporting. And finally, they ask a yes/no question about whether testing is available while the resident is here, and if so, what kind of labs you might be using. For staffing information, the identifier requirements are the same. This is a different form in the CDC system. You need to list the number of confirmed COVID cases among all of those who are working in your facility, as well as suspected cases and COVID-related staff deaths. Same protocols for first reporting. Members must also report any staffing shortages and the type of staffing shortages. Use of temporary or agency staff does not count as a shortage. So if you're relying on help from somewhere, as long as you are adequately staffed, you you wouldn't say that you have a staffing shortage. Although that question always seems a little subjective to me anyway, but don't consider yourself short of staff if you're using agencies. Supplies and equipment. The CDC only wants to know if you have any of these items and whether or not it could last for a week based on your current usage. They do suggest that you use optimal usage parameters to determine if you have enough, but they don't have any real numbers here that you have to quantify. This is about ventilator capacity. I'm not going to go through this because very, very few of you have ventilators. What's a little bit different here is that this is included in the assisted living requirements as well, and I suppose it's possible there could be a ventilator there, but it's not very likely, really. Moving on, Blake. So that concludes the data elements that use the exact CDC definitions. And those elements are the same for all of the entities reporting: nursing homes, AFCs, HFAs, and assisted living. There are a few differences between those groups, between nursing homes and the other groups, in the MDHHS reporting. I have identified those in blue. Another thing here is that you'll note that compared to the way the CDC reports it, these Michigan-specific elements are cumulative, mostly. And you have to look at each element to make sure you've got the right reporting period included. But admissions, total admissions, obviously AL doesn't, they don't have the post-acute setting, so they're not looking at admissions in Michigan. And recovery and discharges, obviously, they're not looking for that as well. The definitions, though, for these are just like the CDC, except for the reporting period times. Here's the additional list of pieces that have to be reported to Michigan specifically. For all settings, again, except for the blue, transfers to regional hubs. We do know that at this point, assisted living level settings are not allowed to transfer to regional hubs, and they're not required to count any of their PPE. However, the number of negatives, the number of pending, those are the two elements that Michigan asks for as of your last reporting. So that is not cumulative, but pretty much everything else is cumulative. Transfers to hospital, those are cumulative. And again, The definitions are very similar to the CDC. Obviously, the transfer to hospital is something new. So those are all of the pieces that are required. We're going to take some questions now, Blake.
All right. I don't have any questions right now, so I will just give that a second. But while people maybe are typing questions, we would like to say each year LeadingAge Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Here's just half of the list of our all the exhibitors that will be at our annual conference and Solutions Expo once we get that back up and running. So thank you to all of them. I did just have a question come in. It says, is the HFA, AFC, ALF data published anywhere? Apologies if I missed this piece.
No, actually, I didn't speak to that. I can't find it anywhere. We do have a meeting next week with the group coordinating that, but we do not have any data about that either, and I would look forward to that to see how that's going.
Real quickly before we move on to the next question, I've received a question via email here. I will make the bill text available for providers to share with our HR departments regarding Senate Bill 690. That way they have the exact language and can make their interpretations if they'd like.
All right, thank you, Dalton and Deanna. I am not seeing any other questions coming through, so it looks like we can go ahead and move forward.
Okay, well, this portion is nursing home specific. Now, there are things that assisted living members might gain from this. It does speak to the department's understanding of the reporting and the testing guidelines. And those testing guidelines are recommended for those other settings, but these rules are only pertinent to nursing homes from this point on. So if you have a busy day, you know, there are no requirements here for AL, but we will talk about the whole issues of testing and reporting in general as well. So moving forward. I did forward to the SNFs through the listserv yesterday what the department called to us the final QA. And they had been working on this for a couple of days, and we did see a couple drafts of it. I planned to review it this morning because they did tell us that they were going to send it out last night. So my understanding is, and I got a lot of feedback this morning, thank you everyone. I asked if it had come out and everyone pretty much said no. But I've decided that we should go ahead and review it because obviously it's not the final guidance, but this is what the department is thinking. And there are some changes from what I was hoping and have been communicating to you all, so I didn't want to delay in going through some of those things. So there could be a few tweaks, but I think the documents pretty much are probably going to mirror what the department's going to say. So basically, the first thing is that the FAQ includes the email address for questions. So if you are challenged by nursing home testing, and we're just talking about testing now, not reporting, there's the email address that you can use to ask. And then the discussion in the FAQ starts with refusals. Residents do have the right to refuse. However, everyone has to have a policy to address it because refusing testing in the department's mind would put other residents at risk. They must be treated as positive until they meet symptom-based criteria for discontinuation. And the FAQ also states that decisions about testing asymptomatic residents should be based on whether or not the facility has transmission. There's a couple pieces that really don't make a whole lot of sense to me because if you're doing facility-wide testing, it doesn't make sense to say that if someone is asymptomatic, you shouldn't worry about their refusal so much if the facility has evidence suggesting that there's little or no transmission, because that's the only reason why you're doing facility-based testing anyway. So that didn't make a whole lot of sense to me. However, basically they believe that residents who decline should be treated as positive. And again, only confirmed positives then should be placed in COVID units. So even though you're treating this person as positive, you should not place them in the COVID unit because you don't have any reason to believe that they're actually COVID positive. For staff, symptomatic staff must be excluded from work. Using the return to work guidance. Asymptomatic staff who refuse to be tested can only work in non-resident areas. Again, I'll be honest with you, that makes no sense to me because all staff have to be tested throughout your entire facility. They've made that very clear that it's not just your direct care workers and your people who are taking care of residents. I suppose that could mean that if you have a different building with a different level of care, that person could work over there. But to say that they can work in other areas, I think you'd have to look very closely what those areas are, because technically you're supposed to test all staff in your nursing home, everyone who's coming in and out on a routine basis. Residents who refuse against the wishes of a power of attorney, they suggest that a medical professional should be consulted with the decision maker to determine if it's medically indicated. And I'm not sure how that would play out. But they also suggest that, and this is based on some recent CDC guidance as well, that you kind of coordinate a discussion between your clinical staff, your physician, the durable power of attorney, and the resident, and try and come to some agreement. And of course, you have to outline in your testing plan, remember that is due June 22nd, how they'll deal with these refusals. Hospice facilities are included in the testing requirements, but not the reporting requirements. So hospice facilities that are licensed as a nursing home have to test as well. Initial testing, there have been a lot of questions about this. The National Guard testing that has done does meet the initial testing requirement, even if the reports have not been received yet. Initial testing, any initial testing that the facility has done on their own before June 15th also meets the requirement, but they want that noted in your testing plan and the dates that all that was completed. Facilities can also have arrangements with local health departments for testing if it's in accordance with the emergency order. One of the issues, and I have talked to them strongly about this because it seemed really problematic to me, that labs cannot return results to anyone who is not the submitter of a sample or a public authority. So if the facility submits, it should be returned, the report should come back to you. However, according to the state, there's no way that other labs, if you're not the submitter, then you're not going to get the reports, and you are expected to ask the employees for copies. I find that an organizational nightmare, and we have let them know that, but that's where it stands right now. Any employees that don't come up with that documentation should not have direct contact with residents, should be working elsewhere, as noted earlier. The testing plan. Again, we've known this from the beginning, but there is some confusion among providers. The testing plans need to be available. You need to have them done. You need to have them done in the next few days, but they don't have to be submitted anywhere. They only have to be available. National Guard will be available through July 27th to assist with testing. They are working to get other state contractors to assist with testing as well, and they will be available as testing allows. There is a local health department testing grid, and providers ask what the heck is that for if we all have to do all this testing. But that is pretty much required as a recommendation of the CDC. Every local health department has a priority list that they have to use if resources become too thin to test everyone. So it identifies what's going on in the local area, what the priorities are for there, and then that guidance is also used to tell the state what the strategy is and what the conditions are in each local area. The order for testing does only apply to nursing homes. That was in the FAQ. I think that's pretty clear to all of us. They asked about what the definition of a recovered person is. A recovered person is defined as those who are still alive 30 days after they were tested positive or the onset of their symptoms. Now, that doesn't mean that they can't come back to work or they can't be out of transmission-based precautions before then. They're just not considered fully recovered necessarily before 30 days. Staff with inconclusive results should be retested. I think that's pretty self-evident. The last day to meet the requirement of testing all staff. The parameters for some of this testing was really confusing. You have to do weekly testing if you're not in 6 and 8, and you also have to do an additional set of testing between June 15th and July 3rd. Any testing between June 15th and July 3rd meets the requirements. If you haven't done your initial testing, you can do your initial testing at that time as well, but you have to include residents. But you have to do staff. Even if you've done initial testing, you have to test staff again between June 15th and July 3rd. The guidance has options for laboratories and supplies and assistance. One of the things is that if you think you need state assistance to do any kind of testing, including your weekly testing, you have to contact the state by June 22nd. And as of yesterday, when we talked to the state, there were only 3 facilities who had done so. So I can't imagine that providers are going to be able to do all this weekly testing without some support. So please notify the state. There is, I think the email for that is in the guidance. Contact them and let them know ASAP. Employees who are not currently working do not have to be tested weekly. That's true, but they do have to be tested before they come back. And some of the local health departments are saying they have to have a negative test before you're going to allow them on the ground. So be prepared for that. Weekly testing means 1 test per calendar week. It does not have to be an exact 7-day period. They understand that there might be some operational difficulty of doing that, but you do have to get 1 test per weekend if you're doing the mandated weekly testing. Facilities can conduct testing themselves if they have the equipment for a CLIA wave test. Now, this is the part that was extremely problematic, and I guess I kept talking to them about this, and every time I did, they came back with more definition. Apparently, this was a big issue because the original guidance said that you do not have to retest persons who are positive, and I was hoping for that, thinking that that was a fairly safe thing to do. But in reality, the CDC has come out with recent guidance that says that you do have to retest after a certain period of time. So if someone has a positive test, you don't test again for 6 weeks. Between 6 and 8 weeks, only repeat if using a test-based strategy. So if you're trying to say, well, this person's no longer positive, and you're using the return to work strategy that is test-based, yes, you test between 6 and 8 weeks. If there's been more than 8 weeks after the onset of illness, you have to include that person in any facility-wide staff testing. And of course, if symptoms return, retest and treat as suspected. So this was different than I had thought and we had hoped, trying to, eliminate the burden as much as we can. However, the CDC feels that for safety, they're not 100% sure that people who are positive could not possibly get the virus again. And so this is the detailed guidance that's coming out. One of the things that the department did say, which I thought was fairly positive, although not helpful right now, is that we've talked about the fact that those regions are just too big and there's too much inconsistency among counties to make a nursing home do all this when there's really no cases around them. And they said that they would give some consideration to a county-based testing plan later. Reimbursement. Lots of questions. I mean, we have submitted lots of questions, have a lot of discussion about what insurances are going to pay for, who's going to pay for all of this. And they did not include that in the draft FAQ. They said that those are still under review by a separate group, and an additional FAQ is scheduled to come out next week, although they haven't issued the first one yet. So it'll be interesting to see what that'll look like. Additionally, they intend these FAQs to be very, very flexible, for lack of a better word. In other words, as they get better ideas and more guidance from CDC, these are going to be changing all of the time. So we're going to have to keep on top of these FAQs when they come out. Another FAQ is when dealing with Medicaid, ensure you're working with a lab that takes Medicaid. Well, I know in the past that it was hard to find a lab that would take Medicaid payments for things. So I don't know if that's an issue or not. And if it is, please shoot me an email and let me know. Because if Medicaid is the payer and you can't find a lab to take it, that's going to be a problem. State-supported testing does not have to go through the State Bureau of Labs. They have included a list of laboratories in the official order that they sent out. There was a question about the timing of testing when results are not available, and the FAQ refers everyone back to the guidance, and we've talked about this with the state, and they do contend that the turnaround time for people being tested now is much, much shorter. It's just those old tests that they're having a hard time. And they suggested you see the guidance for help, but I'm not sure that I don't remember any help being in the guidance about this issue. I guess we're all just going to have to wait and see, and hopefully you'll get your test reports. So that was the FAQ for testing. They put out another draft FAQ for reporting. Hospices do not need to report. Reporting is obviously required an EM resource that will directly send it to NHSN. But even if you're signed up with NHSN, you still have to report daily an EM resource, and I think everyone knows that by now. EM resource reporting in general is cumulative, and it must be completed on weekends. This is where they're clarifying to people that admissions from other facilities and hospitals with COVID should not be included in confirmed or total residents COVID-19 positive cases. So the facility residents, I should include those cases. In other words, acquired cases should only be in confirmed and suspected. Total deaths versus COVID deaths. Apparently, there's been some confusion about that. Sometimes reporting has more COVID deaths than total deaths, which in this area, on the department side at least, should not happen. It's a running total for MDHHS and a daily update for the feds. Some of the state elements go back to January 1. Some people ask if they're counting beds, should they include their SNF beds and their AL beds together? No, you need to report all that separately. AL stuff is completely in Survey Gizmo. They suggest you use the CDC definition of how to report the staff. That's anyone working or volunteering in the facility and coming through your doors on a routine basis. So staff who are out of the facility should be included if recently tested positive. I'm not sure, if it matters where they have gotten contact and become positive, or if they were off for a long time and became positive. But if you're aware of it, you're supposed to report it. They asked for an elaboration of the definition of suspected. I didn't put it there because we have it in an earlier slide, and I think it's pretty obvious what the definition of suspected is. You do have to include your non-available beds in your total bed count for nursing homes. You're not supposed to remove residents who have recovered from your cumulative counts. Once they're counted, they have to stay in there. Much of the rest of this we've covered. PPE inventory, again, should be based on optimal usage. You can use that rate calculator if you need to. One of the important things is that you should check in with NHSN weekly to make sure your data is transmitted, because if it's not, that's where you're going to get a citation. Facilities can, again, report to them directly, but you still have to report to EM Resource. But there have been some problems in transmitting MDHHS data into NHSN. And there is some support for correcting profile information, and you can get that, their help desk on their website. Data entry errors, same things. Discrepancies for MDHHS reporting. There's an email address for data entry errors. If it's on the state side or the NHSN side, there's email addresses for both. So this was our problem list, and I put this out on Wednesday. There are FAQs that I think cover at least 3 of our issues. We continue to tell people at the state that this is absolutely overwhelming, and that members feel, as I've heard, that it's completely unrealistic to be able to apply these resources and deal with the aftermath of all of that. So we continue to work on this problem list. I'm probably going to add a few more things to it and keep working. I won't go through it with you. We went through it last week, but if there are additional issues, please shoot me an email, let me know, because we talk to the state about this on an almost daily basis. Okay, NHSN reporting. They have also, this is the follow-up to the issue that some of the providers in Michigan and elsewhere have gotten citations and enforcement actions and a CMP notification letter. And some of them have been reporting, and it was found that there was a transmitting problem. The state says that the transmitting problem is pretty much fixed, so pay attention to that. We have found 4 of our members who apparently had been cited, and LARA Funch is working with them. CMS suggested first to IDR the issue immediately, but then they also have come back and rescinded some citations. So please pay attention, check your CASPER reports, make sure that you don't have a notification out there that you're not aware of. There are fines, as we know, and you could get a citation under F884. So if you were reporting but were cited, check your identifying information, make sure your data was accurate. They will throw your data out if it appears inaccurate on its face. So that's also a possibility. There's a help desk site, and if you need help, if you have been cited, you need some help, you can contact Laura, who will talk you through the process. So on top of everything else this week, the CDC also issued some frequently asked questions as of yesterday for nursing home data reporting. I think that these are pretty basic, though. I mean, they have to do with why your data looks different than the state, how come what's posted on Nursing Home Compare looks different than what we're presenting, and that's because they don't put all of the data on Nursing Home Compare. You give them daily cases, but they post cumulative cases. And sometimes some data elements on their side might have been eliminated because it looked in error on its face. So it could look like you have COVID deaths, but no active cases. So there's all sorts of little glitches in how data is reporting, so it doesn't always make sense when you look at it, especially on the website. And these are the CDC's responses to all of that. There is an updated QA process. They identified trends in reporting issues and refined some of their filters. They do expect fewer nursing homes to enter imprecise data as things move forward and people kind of get some experience with it. But there is technical assistance available also if needed. And then the CDC put out an update, and this is the update for testing that the state is using to identify the fact that people who are positive do need to be tested, along with other staff if you're doing weekly staff testing after 8 weeks. And that's pretty much what this first part says. Residents who decline, the state has put its recommendations for, that communication piece, and it almost follows the CDC update completely. So there's really nothing new here that we haven't talked about, but it is specific on the CDC website what the follow-up testing protocols are for positives. If staff are declining, you'd still have to presume them COVID positive. The work restrictions would be based on whatever the state and local policies are. So that would vary from state to state. Staff working at multiple facilities only need one test. They do support the ongoing serial testing, what we call the weekly testing or the mass testing. The CDC thinks it's really important, even though it's painful at this point, because when there's an outbreak in the facility, it's really critical, and also as part of the reopening process based on the level of community transmission. So the CDC is pretty much supporting what the state's doing, even though it's a little burdensome. Well, it's very burdensome. Health departments still have to have a plan to prioritize testing. We talked about that. And if staff are asymptomatic during ongoing testing, mass testing, serial testing, they can continue to work. There were some early survey citations for not taking people who were tested off the schedule because obviously, we might think that they have COVID, and that's not the case. So, the CDC has come out and said there's no reason why they can't work. I know that was a lot. I do know that there's a lot of details here, and it's not been an easy process, so I do want to encourage people to continue to talk and send us communications and emails. I really understand best when I know what your stories are, and I have communicated some of those stories de-identified, though, in terms of what the health department is saying and what your ability to get supplies are, etc., to the state, and again, almost on a daily basis. So we can stop now and take questions if there are any, Blake.
All right. Before we do any questions, we would just like to say thank you to our exhibitors again. Here is the other half of our list of people who will be joining us for our Solutions Expo once we get the annual conference back up and scheduled. So if a staff refused ongoing testing, could they continue to provide care as long as they are in full PPE?
That's not my understanding. My understanding is that they must be working in a non-resident area. And I would think that would mean outside the facility based on the fact that all staff in a building have to be tested. So the answer to that is, as far as the guidance says, no.
Okay. We move forward to comply with all staff and all resident testing immediately before June 15th. Does that meet the requirement, or do we have to test again?
If you're in any region but 6 or 8, you have to retest your staff again before July 3rd. Doesn't matter when you did it before June 15th, you have to test all your staff between June 15th and July 3rd. Other than that though, if you have done baseline testing for everyone, staff and residents, prior to June 15th, that counts as your initial or baseline test.
Okay. Can you confirm that once the rest of Michigan moves into the low-risk blue zone on the Safe Start map, that weekly testing will be suspended since those two zones already in the blue are not doing the weekly testing?
That is the plan. One of the things that we have questioned is we don't know the explicit criteria for those colors. In other words, what makes medium versus low, because in some of our counties, we think that we are still low and yet they're still in a medium group. But yes, my understanding is that as soon as your region turns blue, you do not have to do weekly staff testing. However, if you do have a COVID positive patient or a positive staff person, current positive staff person, you have to test residents and staff weekly until 14 days after the last new case.
Okay. Can you please clarify that we do not test again for 6 weeks? So does that mean that staff are out of work for 6 weeks?
No. You can use the return to work criteria, which is either a test-based strategy, in which case you would test if you're using a test-based strategy to get them back to work, or the symptom-based strategy, which is really if there are no symptoms for a certain period of time, you can let your staff come back. They can come back. It's just there's no point in testing them because sometimes the test will read positive for a long time after their onset. So they can come back. You just shouldn't test them. There's no point in testing them because it doesn't necessarily mean anything in terms of whether or not they're positive or not.
Okay, thank you for that. I am not seeing any other questions, so in case anybody is typing anything right now, we would just like to say thank you again to both Deanna and Dalton for all the great info today. We would also like to thank the 75 members and participants that took time out of their busy schedules to join us. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder, for any type of educational event that is coming up, you can go to leadingagemi.org and click on our events calendar and find everything coming up. I know that obviously we will have this COVID-19 webinar again next week, both Wednesday and Friday. Wednesday at 10 a.m. Eastern Standard Time, and then Friday, just like this week, at 11 a.m. Eastern Standard Time. We also have contact emails down there for anybody who needs to reach out to anyone for any further questions. I did have one question pop up while I was doing that. The map has the blue indicated as 7 or less daily cases per million.
Oh, okay. I'll have to find that. That 7 or less. Okay, thank you.
All right. So other than that, I do not have anything else. Deanna or Dalton, would you like to say anything else?
No, just have a good weekend and try to get some rest. Thank you very much. We'll talk to you next week.
All right. Thank you. Everyone have a great day.
Take care.